this includes musculoskeletal work. It includes regenerative, and it includes some amount of sports injuries. So my clinic is a musculoskeletal, sports injuries, and chronic pain clinic. Right now, right. So this is my team here. So these are there are orthopedicians involved. There are rehab people involved, psychologists, visiting neurologists. So this is my team here. Right. So today, the topic is going to be on regenerative medicine. So I'll talk a little bit about what are the indications as a pain physician when you should think about regenerative medicine. We'll talk a little bit about platelet-rich plasma. We'll talk a little bit about bone marrow aspirate concentrate. We'll talk a little bit about SVF. So as pain physicians, you should all get trained in all of these techniques, and they have widespread indications. With growing evidence, this should be part of your curriculum, right? Okay, so where did this all start? So basically what happened was, the good old days, somebody comes with a musculoskeletal pains, a tendonitis, or a partial thickness tear. What we used to do is, we'll say you can take rest for 2 months, 3 months, your musculoskeletal problem will become all right, and you can go ahead and subsequently do your medication and rehab after that. So it all started in normal people, where we ask them to take rest, right? In sportsmen, we couldn't ask them to take rest. So we said, okay, boss, you need not take rest. You will give you something called PRP and see how it goes. So we started doing this PRP. Essentially, the origin of regenerative medicine is actually sports medicine, because we wanted these players to go back and start action very fast. So we started this in sports medicine. Our results in sports medicine for regenerative therapies was so good that we brought this to the general population. So essentially, something that we started with sports medicine, we brought to the general population. Now, when I sit in my pain clinic in Chennai, I see a reasonable amount of musculoskeletal work. So what are the common indications where we should think about regenerative therapies in your day-to-day practice, right? So initially, we started with just 4 indications, right? We started with tendonitis, that is inflammation of the tendons. We started doing it in partial thickness tendon or muscle injuries. We started doing it in partial thickness ligament injuries, and we started doing it in osteoarthritis. So as pain physicians, the MSK indications for regenerative, your core focus should be on all of this, right? Subsequently, now at this point of time, our maximum evidence for PRP and BMAC are also restricted to these 4 indications. Subsequently, you may try this in spine, you may try this in coccydynia, you may try this in the epidural space, intrathecal space. At this point of time, we don't have too much positive evidence for the other indications. So our core focus area for musculoskeletal injuries are these 4. So I'll be concentrating all these 3 techniques that I talked about: PRP, BMAC, adipose, SVF, on these 4 indications. Right. So you are going to see these patients in your OPD. Now, typically, let's say you're talking about a shoulder pathology, your day-to-day rotator cuff injury. You're going to identify this injury. A lot of you, as pain physicians, I'm sure, are getting trained in ultrasound-guided procedures. I love having my ultrasound in my OPD itself. So you can have a quick look in the ultrasound and maybe pick up a rotator cuff tendonitis or a partial thickness tear. The tendonitis you'll pick up by surrounding edema. Sometimes when you put the Doppler mode, you'll pick up more vascularity. Partial thickness tear, you'll be able to pick up where the tear is. If you want, you can confirm the diagnosis of these patients by doing an MRI. Now, a lot of times, the traditional argument has been whether, as pain physicians, we can go ahead and treat musculoskeletal conditions with just ultrasound, or is it mandatory to do an MRI? My suggestion to you is, however good you are with the ultrasound, there are regions in the joint, like the shoulder joint. You cannot see the glenohumeral part of the shoulder joint. So it is advisable to get the MRI whenever you're doing an intervention. One, to look at a region which the sound waves of the ultrasound may not penetrate. And second is for medical legal purposes. So you don't want to treat a partial thickness supraspinatus tear with PRP, and 6 months down the line, somebody says that there actually was a slap tear also, which you missed because you couldn't see the glenohumeral joint in the ultrasound. So to be on the safer side and to be medical legally on the safer side, I would suggest confirm your diagnosis with MRI. So our scenario is somebody comes in with a musculoskeletal injury. You have done the ultrasound in the OPD. You are suspecting a partial tear. You're confirming the diagnosis with the appropriate MRI. Right? Now, depending on what the tear is going to be, you may find different types of tear. Today's case seems to be a shoulder rotator cuff injury. So you may find articular surface tears, dorsal side tears, intrasubstance tears, right? Now, the tears usually are graded, right? So currently, I'm talking about a partial thickness tendon injury, right? So the tendon injuries could be a partial thickness injury. It could be a complete full thickness tear. It could be a full thickness tear with retraction. It could be a full thickness tear with retraction with atrophy. So these are the various stages you're going to see these patients. You may find only tendonitis, partial thickness tear, complete tear with retraction, complete tear with retraction with atrophy. Now, typically, with complete tear with retraction, atrophy, blah, 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 the 2, 3, and 4, you are going to be doing some type of surgical option, which could be an open surgery or an arthroscopic repair. Our area of focus seems to be the partial thickness tear of the tendon. So, the regenerative techniques are typically used in the partial thickness tears. Now, based on which MRI grading you are using, you may get this as grade 1, grade 2, or grade 3 tears. So, partial thickness tear, depending on the MRI, may be graded as grade 1, 2, and 3. So, what is the protocol you're going to follow? What is called as the PRICE protocol. So, this is applicable to almost all musculoskeletal injuries. As soon as patients come, you're going to do what is the PRICE protocol, which is the protect, rest, icing, compression, and elevation. So, this protocol you're going to follow in almost all muscular injuries. The earlier protocol used to be called RICE, only rest, icing, compression, and elevation. Presently, the protocol is called PRICE, protect, rest, icing, compression, and elevation. In the future, if you're doing a lot of sports injuries, it may become something like POLICE. POLICE meaning P for protect, OL for optimal loading, I for icing, C for compression, E for elevation. So probably the most important slide in today's lecture is don't forget the PRICE protocol. Right? So you're going to try the PRICE protocol. Along with that, you're going to give them anti-inflammatory medication, see how they are doing. If they respond to anti-inflammatory medication and conservative treatment, that is enough. You can review this patient after 1 or 2 weeks and start them on a strengthening exercise regime. During this time, you may also give them some supplements like collagen peptides to hasten up the healing. So this is the conservative treatment. So you're going to follow PRICE protocol, use anti-inflammatory medication in the form of NSAIDs or COX-2 inhibitors, and you're going to give them collagen peptides, review them after a couple of weeks, and then see if they are better, put them on a strengthening exercise regime. Now, in a normal patient, you may follow conservative treatment for some period of time, which could be anywhere between 2 to 4 weeks. And if they don't come around, then you think about the regenerative techniques. If you're treating a sportsman where they have to go back to action fast, you may skip this PRICE protocol and straight away go for regenerative therapy as soon as the diagnosis is confirmed with appropriate MRI. Now, we talked about 3 types of regenerative therapy. One is the basic autologous platelet-rich plasma. Then we talked about bone marrow aspirate concentrate. Then we talked about SPF. Now, we'll start with platelet-rich plasma. Now, what's the big fuss about platelets? So why we are worried about platelets is during the normal stage of healing, when you have inflammation, proliferation, and tissue remodeling, which happens over a period of 4 to 6 weeks, the most important um, mediator seems to be coming in because there is an initial rise in local microcirculation, which contains a lot of platelets. Now, why so much interest in platelets? Because platelet seems to be having something called alpha granules, and these alpha granules seems to be filled with a lot of different type of growth factors. So whenever we are talking about platelet, what we get is not stem cell, we get what is called growth factors, which are there in the alpha granule. So typically, platelet-rich plasma or PRP falls into this category called acellular therapy. Acellular means there are no stem cells in PRP, right? So how we did this? We drew blood from typically one of the elbow veins, and then we did a centrifuge, and then we took out platelets. Now, typically, when you draw blood, before you draw blood, you're going to use an anticoagulant. So you may use different types of anticoagulant. Studies are showing the best anticoagulant at this point of time is a substance called ACDA. So that is a convenient and good anticoagulant to be using. After taking anticoagulant in your blood, in your syringe, you're going to aspirate blood. So depending on what container you are using, studies are showing the more blood you draw, the better your results are. So of late, a lot of studies are showing that if you draw 40, 50, 60 ml of blood, the platelet count is going to be much higher. So the healing is enhanced. So categorically, studies are showing that if you are using kits which draw only 10 ml, 15 ml of initial blood, the amount of platelets is going to be inadequate. So use a kit which contains more initial blood. So more blood, better PRP you're going to get. Once you take the blood and you do with the anticoagulated blood, you're going to do a centrifuge. All these are going to settle down in multiple layers. Okay. So you're going to get roughly about 4 layers when you do a centrifuge. So the first centrifuge usually is recommended is somewhere between 3000 to 3500 revolutions per minute RPM, and you can do it for a duration of somewhere around 4 to 6 minutes. So 5 to 6 minutes of spin at 3300 or 3200 RPM is what I would do. After your first spin, you're going to get 4 layers. You're going to get the heaviest layer in terms of specific gravity, the red cells at the bottom. Above the red cells, you're going to have buffy coat. So the buffy coat layer contains WBCs and platelets. Then you have platelet rich, then you have platelet poor. So the bottommost is red cell, then buffy coat, then platelet rich, then platelet poor. So this is basically, it is how they settle based on specific gravity. So the specific gravity of red cells is higher. The specific gravity of platelet poor plasma is very low. So that's how they settle. Now, the initial days, we used to put a long needle and aspirate the middle layer, which contained platelet-rich plasma. Subsequently, our centrifugation techniques improved, and we started using special centrifuges, and we started using what is a double spin technique. So at this point of time, double centrifuge is recommended for doing PRP because the isolation technique seems to be better with double spin, right? So why the big fuss about PRP? Now, studies are showing because it is autologous. So, usually when you talk about regenerative products, autologous means you take it from the patient's own body. If you take it from some other source and then freeze dry it, it is called allogenic. So, you have autologous and allogenic. During this lecture, we are going to be concentrating mainly on autologous products. So, since it's autologous, no possibility of allergic reaction and negligible chance of infection. So, that is safe. It's very convenient. So you're doing it in the same sitting, you're drawing blood and then injecting it immediately. It is autologous, so it's natural, and studies are showing it is very, very effective for treating musculoskeletal indications. So these are the big advantages in doing platelet-rich plasma. So I told you there are alpha granules, and inside these alpha granules, all of these growth factors seems to be present. So these growth factors are super useful in enhancing and kickstarting the healing process. So that's the big advantage why we are after platelets here. Now, what are the indications for PRP. So we have a lot of indications in the joint, a lot of indications in the spine, and the indications are exploding as we go about. So musculoskeletal indications, we do a lot of injections in the shoulder, in the elbows, wrist. We do a lot of injections in the hip, knee, and ankle. So in my clinic, where we do a lot of PRP injections, so the usual indications in the Synapse clinic are supraspinatus, subscapularis, infraspinatus, grade 1 labral tears, grade 2 slap tears, shoulder osteoarthritis, acromioclavicular arthrosis. We do a lot of medial and lateral epicondylitis and intra-articular elbow injections. In the wrist, we do for dequervans, triangular fibrocartilage complex, and intra-articular wrist joint. In the hip, we do for hip osteoarthritis, avascular necrosis of the hip, and in the knee, we do for knee osteoarthritis, chondromalacia, partial thickness injuries of ACL, PCL, MCL, and LCL, and also for patellofemoral pathologies. In the ankle, for medial ankle, we do posterior tibialis tendon, tarsal tunnel. In the lateral ankle, we do it in the peroneus tendonitis, anterior talofibular ligament, posterior talofibular ligament, calcaneofibular ligament, posterior ankle, retrocalcaneal bursitis, Achilles tendonitis, and plantar fasciitis. So these are our core focus area when we do PRP or BMAC in my clinic. We also do some amount of PRP in the spine, but that's for another day, right? So how do I do PRP injection? So by the time you have come to this stage, you have already tried conservative treatment and these patients have not improved with conservative treatment, and then you've decided to confirm the diagnosis with MRI and partial thickness tendon or ligament injury or osteoarthritis. You're going to be doing your regenerative technique. Now, broadly, you can use a commercially available kit. So the commercially available kits are broadly divided into two categories. You have a 2-chamber kit or a triple-chamber kit. So if you are using a 2-chamber kit, you will draw anticoagulated blood, deposit into the kit, and then use the same kit without flipping it to take platelet-rich plasma and platelet-poor plasma separately. If you are using a triple-chamber kit, initially you will draw the blood. Once you do the initial centrifuge, you will lock out the red cells and then flip the centrifuge around, and then the platelet-rich plasma will come down and then you can aspirate. Now, if I'm not going to give sedation to this patient, I may use something like a butterfly. I hope you all know what's a butterfly. So I use a butterfly to draw it from the elbow vein. I usually use a 35 to 40 ml kit. So I prefer larger kits because of better outcome. If I'm going to give sedation, I may put a 20 gauge IV line, and from the IV line, I would draw the blood in the anticoagulated syringe, and I may keep the IV line for subsequent sedation. So if I'm giving sedation, I will keep an IV line. If I'm not giving sedation, I will use a butterfly. I always use a tourniquet, and I always prefer a elbow vein rather than a wrist vein, right? Once I've drawn the blood, I'm going to mix it in my container. So in this picture, I have a commercially available triple chamber container. I've mixed the blood. In the second picture, I'm mixing the blood with ACDA in a 50 cc syringe. I have about 35 to 40 ml of blood, and then I'm putting it into my container here. So this is anticoagulated blood. So the first picture on the left is showing my empty triple chamber container. The second picture is showing the same container with 35 to 40 ml of anticoagulated blood. And then I'm ready for my first spin. So typically the first spin is around 3600 for anywhere between 5 to 6 minutes. So I use a commercially available centrifuge, which is temperature regulated, and I follow sterile precautions. And after the first spin, the picture on the left is showing these 4 layers. So you have the red cell at the bottom, you have the second layer, and then platelet rich plasma, and then platelet poor plasma. So the platelet poor plasma is on top. At this stage, I'm locking out the first chamber. I'm going to flip the container, and then I'm going to go for my second centrifuge. So double centrifuge in a triple chamber container. So after my second centrifuge, you can see the picture on the left. My red cell is on top, which is locked away. And then you have the platelet poor plasma, which is at the bottom, and the platelet rich plasma, which is at the bottom, and platelet poor plasma, which is at the middle layer. So I'm putting my 10 cc syringe here and aspirating platelet rich plasma here. Now, roughly, I took about 35 to 40 ml of blood. You can see I've drawn about 3.5 to 4 ml of good quality platelet rich plasma. So roughly 10 ml of blood is required to make 1 ml of good quality PRP. So it is possible somebody comes and claims that with 10 ml, they'll be able to take out 3 or 4 ml. It just means that the quality of PRP is compromised. So most of the Westerners will agree that for 10 ml of blood, you can draw only 1 ml of good quality platelet-rich plasma. Now, these are the steps that I follow. So I have the container. The first image is the empty container. The second image contains anticoagulated blood. From the second to the third image, I have done my first centrifuge, and then I have locked out the red cells here. Then I flip this container around, and then I do a second centrifuge, and then you have the platelet rich at the bottom, platelet poor above, and then I put my syringe and aspirate my platelet rich platelet counts here. So PRP I draw from the bottommost count here. Now, typically, before I started using this system, what I used to do is I do platelet count after each time I did the procedure. So most of the time when I started, these patients started with something like, so average platelet count is 1.5 lakh to 4.5 lakh. So most of these patients had an average count of about 2.5 lakhs. And after I processed it, the PRP contained about 1.5 million. So 2.5 lakhs became 15 lakhs. So I was able to concentrate roughly about 5 to 6 times of the platelet concentration, which is your target most of the time. So when you do a good spin and concentrate it, you should be able to get about 5 to 6 times the platelet of the initial concentration. Now, lots and lots of kits are available. I'm not recommending any kit. You can use whichever kit you like. My only suggestion for you is use a kit which takes more initial blood, right? So the rules of the game are platelet concentration 5 to 8 times. The anticoagulant choices that you have are ACDA, EDTA, and sodium citrate. Sodium citrate I've used briefly. Sodium citrate causes extreme pain on injection, so I'm not a big fan of sodium citrate. EDTA is one option, but studies are showing that the anticoagulant of choice is ACDA. You have to use sterile swing out technique. Any temperature between 20 to 24 degrees centigrade is okay. Now, if you are using a special centrifuge, it is acceptable. Ideally, the temperature should be regulated. If your centrifuge is heating up and the platelets become warm, they are going to die, right? So you don't want the platelets to go up in temperature. Double centrifuge is recommended. 1 ml of PRP requires about 10 ml of blood. You can keep this for up to 8 hours after centrifugation. Now, there are a lot of activators that are available: collagen, thrombin, calcium chloride. So, a lot of times calcium chloride is added as an activator. But at this point of time, both in India and abroad, clearly the consensus opinion is platelets or PRP injection do not require activation. So at my center, we don't activate PRP. We process it properly and inject it properly. So that's what we concentrate on. We don't activate PRP in synapse pain and spine cleansing. So once you have the PRP, you're going to follow a sterile technique, and you're going to use image guidance, which is usually ultrasound guidance, and you're going to inject it wherever the problem is there. So this is me doing a right shoulder platelet-rich plasma injection. So this patient has got a right shoulder partial thickness supraspinatus tear. So I have drawn blood from the left elbow and I have about 4 ml of platelet-rich plasma in my right hand. Patient is in left lateral. My ultrasound under several precautions is focusing on the left supraspinatus muscle. I infiltrate local with 0.5% ropivacaine and then I inject PRP into the supraspinatus. So this is me doing a right shoulder supraspinatus autologous PRP injection under local anesthesia under ultrasound guidance. Now, you can use whichever centrifuge you like as long as it is temperature regulated and it doesn't heat up too much. If the RPM in your centrifuge is less than 2000, that is probably not the ideal thing. You want the RPM to be between 3000 to 4500. So the spin should be at least 3000 to 4000 RPM. There are machines which can spin at 8000 RPM as well. Now, anything less than 2000 RPM, which is the lab grade centrifuge, may not produce great results. It's not like you cannot make PRP, but it will not produce great results, right? Next is we do this reasonably routinely for sports injuries. Now, what are the things that you need to keep in mind? Good clinical diagnosis, confirmation of diagnosis by MRI, patient counseling, and realistic expectation. Now, this realistic expectation is important. Now, what is the essential difference between a cortisone shot and a PRP shot? Now, in the cortisone shot, the results are almost instantaneous, but basically you are suppressing inflammation with steroid, and so it can cause further damage to the cartilage, and it is short term. So cortisone shots have their indications, but compared to them, the PRP shots are superior and they give long term outcomes in musculoskeletal indications. Now, why I use the word realistic is a lot of times PRP may take 2-3 weeks for the outcome to come. So, a patient should be ready for that. If they are expecting instantaneous relief, it is not for those kind of patients. So, patient should be realistic about the outcome of PRP injection. So, patient preparation is essential and you have to use sterile technique in the OT. So this is some images that I'm sharing. So this is the acromion, this is the supraspinatus. You can see a tear in the supraspinatus. The humerus is below. So skin, subcutaneous tissue, deltoid, and the supraspinatus. And then my needle is inside the supraspinatus. I'm going subacromially, and you can see the PRP has actually inflated the supraspinatus here. Now, this is my colleague, Dr. Vanmati, doing a supraspinatus injection, again under ultrasound guidance. We have a lot of fellows in the clinic, so you can see that what are we doing here? So, patient's head end is on that side, the leg end is towards the screen, the ultrasound is here, and the area of focus is the left ankle, right? So, Dr. Vanmati in this image is doing an injection in the medial aspect of the left ankle. She seems to be concentrating posterior to the medial malleolus of the left ankle. I'm sure some of you may have guessed. So, the tendon behind the medial malleolus, posterior to the medial malleolus in the left ankle, basically she is doing a left posterior tibialis tendon PRP injection. So, this is a left ankle posterior tibialis tendon under ultrasound guidance here. Usually, we have a lot of fellows in the clinic, so you can see they're all very enthusiastic and taking photographs. Now, how do I do this for osteoarthritis of the knee? So, sometimes in osteoarthritis of the knee, I may do it bilateral. So, I have two kits here. So, each of them contain 35 to 40 ml. I have added ACDA. I have used the spin out technique. And then I have about 4 ml of PRP in my hand. And then I use ultrasound guidance to inject into the suprapatellar recess. I come from supralateral to the knee joint, and I'm injecting PRP into the patient's right knee joint here under ultrasound guidance. Right? Now, post PRP, what is your advice? You're going to give rest and immobilization for anywhere between 2 to 5 days. No NSAIDs, no COX-2 inhibitors. So, NSAIDs, COX-2 inhibitors are stopped 1 week prior and 2 weeks post. You can give liberal amount of icing, paracetamol, tramadol is okay. 1 week later, I will review these patients and then start them on a rehab regime. Now, initially, when we used to do procedures, I used to tell them that you may require repeat shots of PRP. At this point of time, I stopped telling them because none of these patients require repeat PRP. If you use a good technique, one injection is more than enough, and then gradually restore range of movement and then strengthen the surrounding muscles, which your rehab team is instructed to do. So typically after PRP, you're expecting recovery after 2 weeks. Major action is in the first 2 weeks. The full recovery may take up to 6 to 8 weeks. So gradually these patients will come around and they'll come around for the long term. So these are the protocols that we follow, right? So we talked about this already. Now, we also do PRP for knee joints. Sometimes you can see the image on the left side. In the image on the left side, I've put 2 needles into the anterior cruciate ligament and I'm doing a intraligamentous ACL PRP injection. So the contrast is showing the ACL here. And most of our indications are around shoulders, ankles, and knee joint in my clinic. Little bit about bone marrow aspirate. So bone marrow aspirate, once we talk about bone marrow aspirate, we are going into stem cell territory here. So you can take bone marrow aspirate concentrate from the anterior superior iliac spine or posterior superior iliac spine. So earlier, what we used to do is whenever the injected place, the patient is going to be supine, we used to take it from the ASIS. When the patient is going to be prone, like spine, we used to take it from the PSIS. But now studies are showing conclusively that the posterior superior iliac spine is superior to the anterior superior iliac spine. So at this point of time, PSIS is the site of choice for bone marrow in my clinic. So we always go for PSIS. And the advantage with PSIS is you can also use image guidance. So you can use your fluoroscope to locate the PSIS and aspirate bone marrow and then inject it, right? So these are your sites. So you're going to be targeting the iliac crest. So I put these points where you should be targeting. So you typically, I told you PSIS is superior to ASIS and you will use your Jamshedi needle. You can use 11 or 13 gauge Jamshedi needle. I prefer using 11 gauge Jamshedi needle. And almost always I do this procedure under local anesthesia and a bit of sedation. I don't remember giving spinal or general anesthesia for bone marrow in my patients, right? So this is me doing a ASIS bone marrow aspiration. The patient is supine. I'm targeting the right side anterior superior iliac spine. So I'm using a 50 cc. So that's a 11 gauge Jamshedi needle into the ASIS, and I'm taking it with a 50 cc vacuum lock syringe. This is aspiration from the posterior superior iliac spine. So patient is prone. Sterile precautions. You can see I'm using the fluoroscope for aspirating from the PSIS. Okay. So once the BMAC is aspirated, you will do a filtration process and then you can do your centrifuge. So once the filtration is done for the BMAC, then it becomes pretty much similar to a PRP and then you can draw the blood. So you can use it in musculoskeletal indications, the ones that I already mentioned, the shoulders, the wrist and ankle, for hips, knees, and ankle. I also do a little bit of spine work. So in this image, I'm showing you intradiscal BMAC. So at this point of time for procedures like this, the evidence is limited. But you all know for degenerated disc, you can do denervative procedures and regenerative procedures. So my needle is inside the L5S1 intervertebral disc here. I also do some amount of endoscopic spine. So after doing an endoscopic discectomy and I have drained out all the irrigation fluid, I may do, after endoscopic discectomy, I may do a BMAC into the disc itself. So you can see the endoscopic trocar is actually still there. And through that, I put a long needle and I'm injecting BMAC into the remaining part of the nucleus pulposus in a disc where I've done endoscopic discectomy, right? A little bit about stromal vascular fraction. Now, studies are showing that in PRP, there is no stem cell. In BMAC, there are some stem cell, but in adipose, there are a lot of stem cells. So adipose is your procedure of choice. So technically, adipose or stromal vascular fraction is superior to BMAC. So you are going to take out adipose from usually from the abdominal wall. So in a procedure which is similar to a liposuction. Okay. So initial cases, I used to call my plastic surgeon to help me. Subsequently, once you become experienced, you can do it by yourself. So you're going to locate. So I have marked the part of the abdomen on the right side. Initially, I inject tumescent anesthesia. Once the tumescent is working well, the tumescent, other than giving anesthesia, will also cause the fat to dissolve. So after tumescent anesthesia, you're supposed to wait for 10 minutes, and then you can use your blunt liposuction trocar to aspirate adipose tissue like this. After the adipose tissue is aspirated, there are two techniques that are used. One is you can do something like an ultrasonic separation technique, because you want to do this with minimal manipulation. So you can use an ultrascopic technique. Something went wrong. Happened. Why is it not
Your
sharing?
slides are not visible.
Yeah, why is it not sharing? Now, 1 second. So after you take your adipose, you can use this ultrasonic device, and then once this layer has come and you have taken out all the local anesthetic as the component of it, you only have the adipose. You can again centrifuge it and take it out. So this is, I hope the video is playing. So this is more or less the technique that we use for aspiration for adipose. And then once this is done, we start the um, sonification process. So this is similar to a liposuction. I'm sure all of you have given anesthesia for liposuction. So this procedure is pretty much done under tumescent anesthesia with a little bit of sedation. Only thing is you have to give tumescent anesthesia and wait for the local to act, and then you can go ahead and aspirate the adipose, right? So in this technique, this is actually my colleague. He's a plastic surgeon. He's taking out adipose. So initial cases, we used to call a plastic surgeon to help us with the adipose. The rest of the processing we used to do. And of course, we used to do the targeted injection. Now, once you do the adipose preparation, you can see the image on the left. So one of my colleagues is taking out the mesenchymal stem cells, which is there in the form of a pellet at the base of the 50 ml falcon tube. And this contains the mesenchymal stem cells. Along with that, you can take some plasma as well. And in this case, we took adipose and we injected adipose into the knee joint. Okay, so this case is probably about 1.5 years old, and I have to say this patient is doing quite well. So in my clinic, we do a reasonable amount of PRP. We do a lot of BMAC. We also do occasional adipose. So these are the options that I do in my practice. Now, regarding the legality of it, now the government of India has clearly showed that as long as you are doing minimal manipulation, adipose is allowed. There is another way to do adipose where you do chemical degradation. We don't follow that technique. But anyway, the focus of this lecture is on PRP and BMAC only. So at this point of time, evidence-wise, musculoskeletal indications for PRP. So the usual conditions have good evidence. For BMAC, the evidence is growing. Adipose is very much at the beginning stage, so it will take maybe 2-3 years more time for a lot of evidence for adipose tissue. But as pain physicians, this is an exciting field which is currently exploding at this point of time. So this is something that you should be trained in doing at this point of time. Medico-legally, you are safe. Evidence-based wise, you are safe. One big advantage pain physicians have over orthopedicians is you can do these procedures accurately because you are masters in image guidance. You can do these procedures beautifully with ultrasound and fluoroscope imaging. So the pain physicians usually have an advantage in doing image guided regenerative procedures. So these are the advantages. So that's my team in Chennai. So usually my clinic is filled with fellows. So lots of fellows are there all the time. So that's my team in Chennai. So thank you very much for the patient hearing. And if there are any doubts, I'm happy to answer. Thank you.
Thank you, Karthik, for a nice, elaborate description of the topic. And you do good work, I must say.
Thank you, sir. Thank you.
I think we keep this open. Anybody wants to ask questions?
Yeah, there are
Prakash,
few questions.
you may handle this now.
So you can handle. We
In
have
the sense,
question.
regarding
No
audio,
problem.
audio
Oh, I have
controls,
seen the
you
doubts.
have
I
the
will.
audio controls, na?
Okay, I have seen some of the
Okay,
doubts.
okay.
I will answer them one by one. So if any of you have any further doubts, please put them in the chat box, right? Now, Dr. Mahi has asked, exactly where do you inject PRP in grade 1 and grade 2 slap tears, right? So ideally, when you're talking about a superior labral anteroposterior tear, grade 1, 2, 3, 4 is what you're going to get in an MRI. Now, grade 1 slap tear, there is some evidence to do it via PRP. Grade 2, 3, 4, it is better to go for arthroscopic repair. So, my indications are predominantly grade 1. Next is, if you are doing a slap, usually the MRI will show you a report where the slap tear, because it's usually superior, is either 12 o'clock to 3 o'clock or 9 o'clock to 12 o'clock. Okay. So the slap, you may get a value in the MRI which says 9 to 12 or 12 to 3. So essentially your target is the glenohumeral joint. So as long as your PRP is going into the glenohumeral joint for a slap tear, you are good. Okay. So if you are doing for 9 to 12 o'clock, you should come posteriorly. So posteriorly meaning you need to come in like we traditionally do an ultrasound guided shoulder injection. So you need to, patient is either lateral or prone. You're going to start scanning from the humerus. As you keep going down, you're going to see the joint. So you're going to see the glenoid, you're going to see the humeral head, you're going to see the capsule. As you come into the capsule, you become intra-articular. And ultrasound guided, I usually prefer coming in from lateral to medial in the posterior ultrasound guided block. And if you come from posterior, it is good for 9 to 12 o'clock slap tears. Now, to tell you the truth, if you're not sure about the other technique, you can use this posterior intra-articular technique for all grade 1 slap tears. But if you want to have a little bit of fun, you can reach the anterior part of glenohumeral joint. How I do it, I'll tell you. So in the anterior part of the glenohumeral joint, what you should scan for is patient is supine. You're going to have your linear probe and start with the long head of the biceps. And then as you keep going superior and medial, you're going to see the subscapularis muscle. So if you track the subscapularis and if you go further medially, you're going to see the coracoid process. So your area of interest is between the subscapularis and coracoid in a patient who's supine and you're coming in from anteriorly. So if you drop your needle behind the coracoid along the subscapularis, you will reach the anterior part of the glenohumeral joint. And once you reach the joint, you will not see the joint in the ultrasound, of course. Your drug has to go freely. So this is the way you will reach the anterior part of the glenohumeral joint. But if you say, I don't want to do all of this, it's fine. You can just reach any technique to reach the glenohumeral joint. For grade 1 slap tear, it is fine. So I answered because you asked where exactly you inject. Next is PRP is not straw colored but tinted with red. What will happen if you inject? Okay, so common doubt that what happens if it is straw colored with if it is red. Now, ideally, your PRP is yellowish, right? So this is your typical straw colored PRP. Now, if there is a tinge of blood red in your PRP, all it means is some red cells have come into your platelet-rich plasma, right? So the better your RBC centrifugation, the yellower will be your PR, right? So it doesn't mean just because a little bit of red cells are there in your PRP, it is not going to work. It doesn't mean like that. So if there is a tinge of red, it is okay to go ahead and inject. So don't waste your PRP just because it is slightly not fully yellow and there's a little bit of red. The little bit of red only means that there are some red cells that are there in your PRP. It doesn't matter. You will get same efficacy. Okay, so don't worry that you get a little bit of um, uh, red. So yellow is fine, red is fine, equally efficacious. Don't break your head about. Next question: what do you prefer, PRP, GFC, and why? So Sri has asked me that question. Now, whenever you say growth factor, right? So basically, you are adding an activator, right? Sometimes company will say what activator they are adding. There are some companies in India which I know which will not even reveal what activator they are adding, and they expect physicians to not even know what substance they are adding, but they expect physicians to use that product, right? Now, if you have read enough, you will know that the most common activator that is used is calcium chloride. Right? Now, my problem with the GFC kits that are there in India is not the activator. My problem is the initial quantity of blood. So, a lot of these kits that are available use 10, 15, and 20 ml of initial blood, and this 15, 10 ml, I'm sorry to say, is not enough to make good quality PR. Now, if you see worldwide, the GFC you will hardly find outside India. This is just a marketing gimmick. The GFC is promoted as if it's the holy grail. In India alone, you don't find any studies which show that GFC is superior. It's not used in the US, it's not used in Europe. You hardly see GFC outside India, right? So at this point of time, if you want to follow the international consensus, good quality PRP with initially large quantity of blood is more than enough. In my book, PRP is better than GFC. I never use GFC at all. I use only PRP. So there are only two techniques that are important. A lot of studies that are coming out from the West are showing initial volume of blood should be 40, 50, 60 ml. So 60 is the recommended new normal to create 8 to 10 billion platelets. Okay, so your target is anywhere between 6 to 10 billion platelets. So you should get anywhere between 50 to 60 ml of initial blood. So the quantity of initial blood, double centrifugation technique is more important than your activator. So concentrate on taking more initial blood. And in my book, GFC is not um, um, something that I would recommend. I prefer PRP over GFC. More questions are there?
Explain PRP in SNR injection.
Now, I assume you're talking about selective nerve root injection. So, PRP in SNR, now selective nerve root, the thing is, I have tried my fair share of spine injections, to tell you the truth, and have not had great results with spine. So that's the truth of the matter. Okay. So I have tried enough. I've done it caudally, I've done it epidurally, I've done it in selective nerve roots, dorsal root ganglion, in tailed back. To tell you the truth, my results have been equivocal, 50-50, right? So the thing is, in SNRB, even if you put saline, you will wash away the inflammatory mediators and some effect may be there. So at this point of time, you are better off using local with steroid in SNRB. PRP at this point of time is again, experimental is what I would say. So I don't recommend PRP in SNRB. So that's my answer. So I'm not recommending PRP in SNRB. I've tried enough. My results have not been that great. What stage we can inject PRP and what is the protocol after injection? I showed you all that in my slide, I think. When to use leukocyte poor, when to use leukocyte rich. Okay. Now, leukocyte poor PRP was initially recommended for osteoarthritis of the knee. So what you should do is, other than the standard preparation that you are doing, you need to use a leukocyte filter. So the leukocyte filter is available in India for an extra cost of 3,000 to 4,000 rupees. So if you use the leukocyte filter, you get leukocyte poor PRP, and the leukocyte poor PRP means it doesn't trigger inflammation. So in tendinopathy, partial thickness ligament tear, partial thickness tendon injuries, normal PRP is leukocyte rich, platelet rich plasma is recommended. If at all there is a role for platelet leukocyte poor PRP, it is in osteoarthritis of the knee. In osteoarthritis of the knee, you don't want to increase the inflammation further. So there is a school of thought which says that leukocyte poor PRP can be used for knee osteoarthritis. Fair enough. But to tell you the truth, only constraint is it adds a little bit of extra cost. So if you don't mind, you can go ahead and use leukocyte poor, the leukocyte filter to make leukocyte poor PRP. That is one. Sometimes people will say take off the buffy coat because the buffy coat contains leukocyte. But if you throw away the buffy coat, you will lose a lot of platelets also. So throwing away the buffy coat is not something that I would recommend. So at this point of time in India, the only correct way to make leukocyte poor PRP is the leukocyte filter. Now, in my practice, most of the time, I almost always combine PRP with HA for osteoarthritis knee. Because I combine it with HA, the HA acts like a substrate and the initial pain and inflammation is taken care of by the HA. So in my practice, since majority of the time I use PRP plus HA for osteoarthritis of the knee, I don't see the big need to use leukocyte poor PRP for osteoarthritis of the knee. So in my practice, I don't use leukocyte poor PRP for osteoarthritis of the knee. But again, I'm not saying you should not. You may use it because I told you the advantages. So if at all there is an indication for leukocyte poor platelet rich plasma, it is in osteoarthritis of the knee. But since I most of the time combine it with HA, I just use the normal PRP for knee osteoarthritis as well, and my results are acceptable. I think we have finished.
I think all the questions are finished. Yeah.
Yeah.
Anybody else?
And
If they have any
finished it
questions?
at 10 p.m. dot.
Yes,
Yes.
absolutely.
Sir,
Yeah.
how much volume you give combine HA and PRP in osteoarthritis knee?
Okay, so what volume I give? So my HA is the company that I use produces 4, sometimes 5 ml of HA. So I use 4 ml of HA, and the PRP that I would get is roughly about 4 ml. So a lot of times, if you are reasonably senior and you know what you are doing, for us, see, the knee joint can take 15-20 ml. So no problem. You're not going to cause some toxicity. So sometimes what I do is I will take 4 ml of platelet rich plasma, and then I may take a little bit of platelet poor plasma as well. So I may take 4 ml of platelet rich plasma and maybe another 3 or 4 ml of platelet poor plasma. So my plasma concentration increases, volume increases to somewhere around 6 or 7 ml. So I put the needle into the suprapatellar recess with ultrasound guidance. My local anesthesia of choice is ropivacaine because ropivacaine 0.2% is, studies have shown, is the least toxic. It doesn't have any detrimental effect on PRP. And after I inject a little bit of local, I will inject 4 ml of HA followed by this 6 or 8 ml, which contains PRP, a little bit of platelet poor plasma as well. So 4 ml of HA plus 6 or 8 ml of PRP. That's my volume.
Okay. Thank you, sir.
Hello, sir. I have asked one question. At what stage of injury you inject the... Hello?
Yeah, I think we talked about this in the lecture. You are not there?
It's, suppose if patient comes immediately after injury and the patient has severe pain, so at that point of time, can we inject PRP or we need to wait for some time and then we have to inject the PRP?
Now, I will make the decision based on the patient's profile. Now, if you are looking at a sportsman, right? So, your approach is going to be different. If you are looking at a normal patient, your approach is going to be different. So, majority of your day-to-day patient is not a sportsman. They are normal people. So, if your patient is not a sportsman and time is not such a big constraint, you will initially treat them conservatively, which is your price protocol, rest, icing, and anti-inflammatory medication, and see if this patient comes around with conservative treatment. So, your COX-2 inhibitors for 5 days, proton pump inhibitors, collagen peptide, rest, icing, and review them after 1 week. And if they are better, you treat them conservatively. If they are not, so that means they go to rehab. If they are not better, then you will think about PR. Now, to tell you the truth, partial thickness of shoulder rotator cuff injuries is not such a painful condition. One. Second is, if it is a sportsman and time is a constraint, I will straight away go for PRP in a partial thickness tear. So, sportsmen, straight away confirm diagnosis, go for PRP. Normal people, give anti-inflammatory, rest, icing, see if they improve. If they don't improve, think about PRP.
But sir, if we inject the PRP immediately, then it will give inflammation and give pain more, no? Patient will feel pain more.
Not such
So
I mean, I have not had such traumatic experience. So, if you want to be really so much, I mean, you don't want to cause any pain at all, 2-3 things can be done. One is, if you don't want the patient to have pain, you should ask him not to move. So, a lot of times what I may do is, my usual post PRP injection medication is either tapentadol or tramadol along with liberal dose of paracetamol. So, I give at least 2 to 3 grams of paracetamol, either tramadol or tapentadol. So, these are acceptable for me. Along with that, rest and icing for 4 to 5 days. Now, if the patient is really tender, I may put a shoulder sling. So, if you put a shoulder sling, the patient is going to do minimal movements and that is going to help you. And in spite of it, if you want to cover, since you can't give NSAIDs and COX-2 inhibitors, worst case scenario, you can put a fentanyl patch. There have been times when I've done regenerative techniques and the patients have called me in the night and I put them on a 12.5 or 25 microgram per hour fentanyl patch. I don't think it's that traumatic. I've done enough PRP. Nobody cries with PRP.
yes. Okay. After 5 days, we can mobilize the patient.
Correct.
Yes. Okay.
So you
Thank you.
mentioned
Right,
that
Dr.
if it is-
Karthik. Yes, is there any question?
May I please ask one question, sir?
Yeah, please.
Yeah, last one. Yeah, sure.
Sir, since you said that if it is a good quality PRP, then most of the time it is only one cycle that you do. Sir,
Correct.
is it the same case both for the injuries and for the degenerative, like osteoarthritic changes, or like for
Yeah.
osteoarthritis, you need to do more?
So, initially, when we are doing PRP, the good old days, I used to say them that you may require second or third injection, right? So, we'll divide this into tendon injuries, ligament injuries, plus osteoarthritis will come to later. So, tendon and ligament injuries, the cases which have very bad tears, that is extensive tear, but it's still a partial tear, some fibers are sticking around. So, in those cases, the good old days, I used to say repeat PRP injection. Now, nowadays, what I do is, if the tear is very big, instead of PRP, I straight away go for BMAC. So, that's the way I'll do it. Now, osteoarthritis of the knee is the only indication where I may repeat PRP. But generally, since I have all these techniques and I'm very comfortable with all of these techniques, what I will choose is whenever I think a second PRP injection is required, anyway, for musculoskeletal, that is tendon or ligament, or for osteoarthritis, whenever I think second injection is required, I will change from PRP to BMAC. So I will change the product whenever I think the second injection is required. But having said that, some clinics have a protocol where they repeat for osteoarthritis, grade 2 and grade 3s. They may say we are doing PRP in first week, and then another injection after 1 month, another injection after 1 month. So that is acceptable as well. So for osteoarthritis, if you want to repeat PRP once a month for 3 months, that is acceptable as well. Sometimes what they will do is first injection, they will do PRP plus HA, then second injection, only PRP after 1 month, third injection, PRP after the second month. So that is acceptable as well. Only thing that I'm requesting you all is don't waste your time trying to cure grade 3 or grade 4 osteoarthritis with PRP. So grade 4 osteoarthritis, bone on bone, varus deformity, valgus deformity, don't waste your time doing PRP because you will burn your fingers, you will not get good result. Not only will you not get good results, you will lose confidence and thereby bring bad name to the procedure itself. So if you are doing for osteoarthritis of the knee, concentrate on grade 2s and 3s. Grade 1s you can manage conservatively. Don't try doing these procedures on grade 4 patients because you will get bad result. Grade 4 osteoarthritis of the knee is for TKR. You cannot cure grade 4 osteoarthritis with regenerative medicine. I hope you, it's like a take home message. So keep this in mind. Thank you.
Thank you, sir.
Thank you, Karthik, for such a nice lecture and, of course, answering all the queries. Hope this definitely becomes very useful to all those who are listening this. So, Prakash, shall we conclude here?
Yes, we can. If there are no more questions, we can conclude.
Thank
I
you
think
very much,
all are
everybody.
clear.
Dr. Prakash, Dr. Karthik, and all the listeners. Thank you very much.
Thank you.
Thank you for having me.
Thank you, Karthik.
Thank you all. Good night.
Good night. Good night.
Good night.
Good night.